Recording in
Hi, everyone. My name is Faith, and I am with Metro Council. Metro Council is the Metropolitan Council of Community Mental Health Centers, and it is a collaborative membership organization representing the public mental health system of community behavioral health centers serving the greater metropolitan Kansas City area. We provide support for our member organizations in education, information, and resources to the public on accessing quality health services. We host the Mental Health KC Conference every May, as well as provide free webinars on the second and fourth Thursday of every month. Our 2025 Mental Health KC Conference is occurring on May 29th and 30th at Johnson County Community College. You can check your email to read a little bit about our keynote speakers. Registration is now live, and I will add the registration link to the chat box. Something new this year is that we have pre-approved CEUs available for those who want or need official CEUs. I recommend that you register before May 15th for the early pricing, as prices will go up by $25 on May 16th. As a reminder, the views and opinions presented are those of the speaker and do not necessarily represent the opinions of Metro Council. At the end of the webinar today, I will put a link and password to get the certificates of attendance for the webinar. Now, with all that said, I am very excited to introduce Dr. Tahirkheli. He will be presenting on affective instability in the assessment and treatment of psychiatric disorders.
Hello, everyone. Let me just get my slides shared here. Thank you all for joining today. Excited to be presenting this important topic. Oh, it's saying the host isn't allowing sharing for this webinar.
Oh, give me 1 second. Are you able to share it now?
Yeah.
Perfect.
All right. So I am Dr. Momin Tahirkheli. I'm one of the PGY2s in the psychiatry program here at UMKC. I'm going to be presenting about affective instability in the assessment and treatment of psychiatric disorders. It's a topic that's very interesting to me. I actually had a patient that had a presentation that made me very interested in this topic. To begin, I don't have any disclosure statements. I don't have any actual or potential conflicts of interest to disclose related to the products or services discussed in this presentation. Some of the learning objectives I'm going to be talking about today, I'll start with assessing a discussion on just overall assessment of affect on mental status evaluations and exams, followed by a discussion on affective instability within psychiatric and medical conditions. And finally, a little bit of a discussion on strategies to manage affective instability in clinical practice. To start, I wanted to kind of touch on mood and affect. This is a pretty classic example of definitions and terminology that can be really confusing. I remember as a medical student that this was kind of difficult to understand and conceptualize in my mind. So I want to clear up some things today. Knowing the differences between mood and affect is a vital aspect of the mental status examination. And assessing these is very important, especially because changes and abnormalities in relation to these findings on mental status exam can dictate clinical decisions on a daily basis. Descriptions and definitions can also be kind of understood differently amongst practitioners, even within a specific field or discipline. Even among psychiatrists, they may not agree upon the definitions of mood and the definition of affect. Certainly among a multidisciplinary team, these things can differ. So I encourage actually just communication with amongst peers and colleagues of different disciplines to discuss what you're actually referring to when you talk about mood and when you talk about affect, so that we can kind of have a more standardized approach to how we describe these things. To begin, for affect, the definition that I usually use and that I refer to is that affect refers to simply a feeling or an emotion. It's typically in response to an external event or a thought, and it's commonly referred to as the outward expression of the emotion. So kind of the facial expressions, the tone of one's voice, how they look, what they're actually expressing, and the emotion that they're expressing. Whereas mood, in the definition that I typically use, mood is more of an inner state, and it's something that persists for some time, usually at least a couple of days or maybe even a couple of weeks. And a mood can have an underlying disposition for someone to exhibit a particular emotion or affect. For the descriptors of affect, you want to kind of talk about the range. Range can be full or broad, someone who's smiling when it's appropriate, laughing when it's appropriate, or even sad or kind of more frowny face, like when they're sad, or if the context of the conversation is more kind of morbid. Or it can be restricted. Someone can have no change in their emotional expression throughout an entire evaluation, maybe even 40 minutes. So that would be more of a restricted or constricted range. Fluctuations in the affect, you want to describe whether their facial expressions are labile, whether they're changing frequently, changing and rapidly shifting in intensity as well. Something more stable should be also defined and should be noted, or expansive, where you may see someone fluctuate from more of a stable affect to very energized or high energy suddenly. The intensity should also be noted. Someone can have a normal affect, flat, blunted, or energized as well. And an important aspect of affect that I always try to include in my assessments is congruence. So an incongruent affect would be if someone is saying that they are happy but clearly their affect is showing some kind of a sad, more blunted kind of affect. And if it's congruent, then they'll say I'm in a happy mood, and they'll be smiling, they'll be laughing. So that'll be congruent with their mood or the stated thought content that's being described. And affect can also have a quality to it, which is more overarching and general. So in overall, when we talk about mood and affect, and people interested in the mental health field or practitioners in the mental health field can also see that there are several ways to kind of conceptualize mood and affect. The model that I like to use is one actually that I kind of found in the DSM-4. It was in the glossary, that affect is kind of like the weather. It's more momentary. It can shift within a few moments. And mood is more like a prolonged emotion, like the climate of an area. So the kind of definition I like to use is mood is climate, affect is the weather. Typically, when I'm assessing someone's mood, I'll ask them what they think their mood is, how their mood is. And when I'm documenting that, I'll put it in quotations directly how they describe it. And affect is something more that I'm assessing. I don't necessarily ask someone how their affect is. I'll just be kind of describing that myself. So I kind of mentioned that this whole presentation was inspired by a specific patient that I actually saw on my forensic psychiatry rotation in my first year of residency. I wanted to give and include kind of a brief case presentation and what inspired me to make this presentation today. So this was a male in his late teens. He was admitted for a competency restoration at the Center for Behavioral Medicine. He was assessed to have interfering symptoms in his overall legal process, consisting of possible underlying psychotic symptoms. When we initially interviewed him, he presented with significant anxiety and depressive symptoms, very hopeless, frustrated. And his past psychiatric history was significant for a diagnosis of schizoaffective disorder bipolar type, as well as borderline personality disorder and amphetamine use disorder. While we obtained the social history, he also described a significant neglect in his childhood and stated that a particular thing that was Contributing to his presentation was being estranged from his father for a long time. On mental status exam, this was a young male. He appeared very fidgety, frequently distracted, looking around the room, looking outside the window, kind of agitated with some increased psychomotor activity. He was tapping his feet, fidgeting with his fingers and his hands. But his speech had a normal rate, normal volume, wasn't significantly rapid or pressured. He did notably have some poor concentration. We had to ask questions multiple times so that he could finally give us an answer. And there was also some questionable comprehension of questions too. He kind of would just answer yes or no randomly, sometimes not really understanding what he would be saying. He was also very distracted by environmental stimuli, but he didn't really appear to be responding to internal stimuli or auditory or visual hallucinations, and he denied experiencing these. And he described his mood as frustrated. This was congruent with his affect. His affect was congruent with that mood. He was slightly labile as well, and irritable and hyperreactive. The interesting aspect to his presentation was about a week into his hospitalization on follow-up, we were meeting with him as a multidisciplinary team, and he had this episode, kind of brief moments where he would be staring at members of the team and would just start laughing uncontrollably throughout the interaction. And this was not just like a momentary thing. This lasted like several minutes. And we couldn't really ascertain why he was laughing. He was just kind of laughing inappropriately during the interaction. He couldn't control his laughter. When I followed up with him later in the day, he also told me that sometimes he would experience uncontrollable episodes of crying too. And these outbursts weren't really consistent with his underarching mood. He told me that sometimes he'll start laughing even though he feels sad and kind of anxious. And he also told me that he would start crying although he would be in an okay mood and feeling all right. So this really got me thinking that his primary kind of presentation was significant for abnormalities in affect. And this is something that's hard as a first-year resident, even someone that's pretty much an expert in psychiatry, to detect. And using affect for diagnosis and creating a treatment plan can also be very difficult as well. So I wanted to challenge myself and wanted to really dive in deeper into this overall construct of affective instability. And I looked into the different medical conditions and causes of abnormalities in affect and came up with a pretty broad list. So many medical conditions such as infection, autoimmune pathologies, thyroid problems, even abnormalities in the HPA axis, metabolic derangements, a lot of these things can contribute to changes in affect. Neurological conditions like strokes, traumatic brain injury, even tumors, epilepsy can also cause changes and shifts in affect as well. And of course, we're psychiatrists and we work at the Center for Behavioral Medicine. So definitely we cannot overlook primary psychiatric conditions that can be causing abnormalities in affect too. For the initial workup, we definitely wanted to rule out any potential medical causes or at least common medical causes. And so we got overall labs, routine admission labs, and really we were asking ourselves this question: what medical or neurological causes would there be for emotional incontinence or affective lability or instability? We weren't really used to seeing something like this. The patient's labs were largely normal, and there was nothing that really stuck out on his labs. Social history was relevant for a traumatic brain injury secondary to a significant motor vehicle accident that he had sustained in his childhood. He even described losing consciousness and that he didn't really have a good memory of that situation either. So that was something that we wanted to further kind of explore. And taking into consideration that the primary features of his presentation were these brief episodes of emotional incontinence, anxiety, disorientation, and even concerns for comprehension, something like a traumatic brain injury was definitely not off the table. Diagnostic implications at this time, still pretty broad. Of course, there are underlying psychiatric and primary psychiatric conditions, mood disorders, thought disorders, personality disorders that can have presentations such as this. But we also didn't want to get rid of the possibility of a neurologic disorder. We got an MRI, and later this was confirmed to have no anatomic abnormalities. But we were initially thinking that, this might be something different, like such as a pseudobulbar affect, and didn't certainly wanted to rule out any potential neurologic problems first. After getting the MRI, after doing a thorough neurologic examination, neurologic evaluation, we then started to consider primary psychiatric disorders as the mainstay of what we're going to give this guy for a diagnosis. And we asked ourselves, well, how does affective lability vary between psychiatric disorders? Can we use this specific feature of his presentation to diagnose him with a specific condition? Can we use this for treatment recommendations? We didn't really know at this time, so we looked into it. When I looked into affective instability, the first thing I tried to determine is what is this exactly? As we know, affect in and of itself as a construct is kind of difficult to parse out, even for good psychiatrists. But when we looked into it, it still was very far from clear. We found out from a review of the literature that it's very poorly understood. Some frameworks define it as a more stable trait that's inherent, maybe even more something related to someone's temperament, as expressed in personality disorders or even attachment disorders. But other frameworks define it as a symptom that's more commonly seen in bipolar disorder or borderline personality disorder. There wasn't a clear reconciliation of this upon my initial glance at the literature. I looked a little bit deeper into the available literature. One systematic review published in 2013 looked at several studies and wanted to evaluate definitions of affective instability and measures of affective instability. And they basically found that affective instability is a term that, or even emotional lability or other kind of related terms, are frequently used and described in the psychiatric literature and in clinical settings, but there's no real standardized measure or definition that exists for this term. In the review, a total of 24 distinct measures were identified. So you can see that this is not something that clinicians are utilizing the same assessment tool to really assess in a clinical setting. And there may be a lot of inter-test reliability issues, validity issues as well, if people are using different kinds of assessments and standardized assessments to define this or to characterize with specific patient situations. This systematic review did propose a definition, though, with three core elements being rapid oscillations of affect, intensity of affect, and a difficulty in regulating these oscillations or their behavioral consequences. So in general, rapid shifts in intense affect and just difficulty with overall control. When I looked at how affective instability is measured, as I mentioned before, it's very variable. A lot of studies use different measures. Most of them are retrospective, self-reported scales. The one that I wanted to look at a little bit further, which I saw was included in a lot of different studies, even meta-analyses, was the affective lability scale, short form. So this is an 18-item scale, includes 18 questions. It was kind of devised from an original 54-item scale. That's why it's called the short form. And each of these questions is going to be administered to the patient in question, and the patient will respond with a rating on a 4-point scale. So you'll ask questions like, 1 minute I can be feeling okay, and then the next minute I'm tense, jittery, and nervous. And the patient will rate this as a 1 to a 4, 1 being very uncharacteristic of how they feel, and 4 being very characteristic for how they feel. And this is a nice form because its validity has been tested in a lot of different studies, and it's a very valid score, valid assessment tool. and inter-rater reliability is very good as well. There's also a form that can be used for adolescents too, because certainly adolescents struggle with impulse control, affective instability as well. And as you can see here, this form also has 3 different subscales or subcategories that show oscillation between affective states, from anxiety to depression, depression to elation, and then anger. So just a little summary for overall what we've discussed so far. As we can see, there's a lot of variation in the definition of affective instability, variation in the definition of affect itself. Assessments are variable, and many different assessments exist. I gave you an example of one, but there are many different assessments that are out there. And the question came to mind, can affective instability, can this feature of someone's presentation be used for something like establishing a diagnosis for someone? And that's still unclear. We'll get into that a little bit here coming forward. But I argue that it may not matter, and I'll tell you why. For affective instability, there's a case control study published in 2018, which compared people with severe mental illness consisting of diagnoses of bipolar disorder, borderline personality disorder, major depression, or psychosis. They were compared to 25 primary care controls. And it was significant that the individuals with mental disorders, psychiatric disorders, demonstrated much higher levels of affective lability and lower affect control. Interestingly, affect intensity was found to be less helpful. And so this was a specific finding, like with high affective lability, it shows some impairment in functioning, some definite psychiatric condition that may be at play here. So it can be a tool here that could be used for a clinical target for an intervention. It can also be a tool that can kind of gauge how much impairment of functioning someone can have independent of diagnosis, and how this specific feature of a presentation can adversely impact day-to-day functioning. So when looking at affective lability across disorders, several studies have sought to differentiate affective lability within psychiatric conditions. We'll start with looking at mood disorders. There was a study amongst Chinese patients with mood disorders, and a Chinese version of this short form of the affective lability scale was used. It was determined to have good reliability and validity in differentiating between major depression and bipolar disorder. It was even found that utilizing the affective lability scale could even help decrease risks of misdiagnosis. Now, this is something that clinicians in psychiatry struggle with on a daily basis. The question of whether someone has a history of mania, whether someone has bipolar disorder or unipolar major depression. And this study showed that just assessing affective lability may help delineate whether someone struggles with unipolar depression versus a bipolar disorder. Furthermore, looking deeper into mood disorders, specifically with bipolar disorder, affective lability presents in the early stage of the development of the disease. It also presents in inter-episode periods of bipolar disorder between those periods of mania and depression. Can also be a significant presenting factor in depressive episodes, and can even present in unaffected first-degree relatives of individuals with bipolar disorder. So in this way, assessing affective lability can be an essential clinical tool in clinical practice to monitor the progression of mood disorder, or even suggest someone may have bipolar disorder if they have a family history before presenting with a manic episode or a depressive episode. Next, we'll look at psychotic spectrum disorders. One study looked at individuals that struggle with schizophrenia or bipolar spectrum disorders compared to healthy controls from the same catchment area. And this study found that significantly higher levels of affective lability were present in individuals with a psychiatric condition compared to controls. Although there weren't significant findings to suggest differences in affective lability between individuals with schizophrenia or bipolar spectrum disorders, this study still suggested that overall affective lability can be used as a potential target for treatment in psychotic disorders, especially when considering a lot of the time diagnosis is unclear. Clinicians may not have 100% proof or 100% reliability in diagnosing either a primary thought disorder or a mood disorder. And in this case, using affective lability may help be a target for treatment overall for someone in an acute crisis. Next, in terms of trauma and affective lability, a really interesting finding here amongst individuals with bipolar disorder and mood disorders. There was a strong link found between elevated levels of affective instability, childhood trauma, and bipolar disorder type 1. And this could even indicate the link between exposure to childhood trauma and the actual disorder of bipolar disorder. Another study also found that affective lability may be the mediating component or association between childhood traumatic experiences and the risk of developing more severe complications or features of bipolar disorder, such as self-harm, suicidal ideation, and more severe features as well. When looking at borderline personality disorder, this may even be the first condition you think of when thinking of affective lability. Specifically, there have been studies looking at how to differentiate borderline personality disorder from bipolar disorder, specifically type 2. And a lot of this study actually suggests that with bipolar disorder, you can expect a different flavor of affective instability, with overall increased intensity of affect and more frequent shifts to positive emotions and elation. Specifically, people in the bipolar group were found to have higher scores with oscillation between euthymia, or a normal affect or normal mood, to an elated mood or elated affect. Also, they were found to have higher total affect intensity measure scores and higher scores on the affective intensity measure positive emotion subscale. In people with borderline personality disorder, a clinician could expect a different flavor of affective instability with more frequent anger, more frequent anxiety, and shifts from depression to anxiety or depression to anger rather than elation. So here we can see that using affective lability, one can even begin to parse through suggesting a diagnosis of borderline personality disorder versus an underlying mood disorder, such as bipolar disorder. Overall, with the review of the literature, despite the fact that there aren't standardized assessments that are used by clinicians worldwide for assessing the condition, and the fact that there are many assessments available, also, despite the fact that some of the
Standardized assessments are empirically developed evaluation tools with established statistical reliability.
Sorry about that, Siri. But also considering that a lot of differences exist with the definitions of affective instability overall. From the review of the literature, we can ascertain that affective lability can be a prominent sign or symptom of many psychiatric disorders. It can also, in mood disorders, reduce misdiagnosis between unipolar and bipolar depression. It can be used as an important tool to assess disease progression, specifically in bipolar disorder, and can also serve as a target for treatment in psychotic disorders, mood disorders, and personality disorders. Furthermore, affective lability may mediate the relationship between childhood trauma and severe features of bipolar disorder. And I believe that assessing affective lability and affective lability scales can especially be useful in situations where there's diagnostic ambiguity. Typically on an inpatient unit, you may not know or may not have sufficient collateral information to decide on a diagnosis. So if someone is presenting with significant affective instability, it wouldn't hurt to get a score on an affective lability scale and maybe even use it as a treatment, something for a treatment target. Now, So we've kind of talked about overall definitions of affective instability, affective lability, how it can be difficult to assess, but there are some assessments we can use for assessment, and how important it can be in diagnosis, in assessment of disease progression, and even as a target for treatment. So what does this actually look like in clinical practice when we're talking about management of affective instability? I kind of separated this out into two different strategies or two different categories, talking about psychotherapeutic-based approaches and then pharmacologic treatment approaches. Firstly, before I move on to these two specific strategies, I wanted to give some general tips. I know that there may be some people in the audience that may not be specifically working in a psychiatric facility or even in a psychiatric setting, but certainly these tips can be useful even in engaging with any patient that's struggling with affective control or impulse control. Definitely, there are situations on even the medical floor or surgery floors where patients get agitated. So there is a consensus statement from the American Association of Emergency Psychiatry that was published in 2012, giving some general tips for clinicians and ancillary staff as to how someone can approach verbal de-escalation and generally de-escalating situations where people may be starting to develop some aggression. To start, it's definitely important to respect personal space. You know, as the clinician or anyone engaged in trying to de-escalate a situation, you have to demonstrate body language that doesn't appear harmful to the patient. You need to show that you're willing to learn, that you want to listen, and that your primary goal is everyone's safety in the situation. Your hands should always be visible, should not be clenched, and try to avoid other non-verbal cues like rolling up your sleeves or even concealing your hands that may give the patient an idea that you may be concealing a weapon or something like that. It's also advised that your knees should be slightly bent, and the clinician can also try to avoid directly facing the patient or engaging in intense eye contact with them. Try to have intermittent eye contact and seem unassuming. It's also very important to not be provocative. So remaining and maintaining a calm demeanor with kind of stable, benign facial expressions is very important. Excessive direct eye contact should definitely be avoided, and staring can even be seen as an act of aggression from the patient's side. I would also try to establish verbal contact. And when trying to establish verbal contact, it's advisable to kind of have one individual be the primary person interacting with the patient. This is important because if the patient starts hearing two or three or even a whole mob of voices, they'll get easily confused. And this could even further escalate whatever crisis they're currently going through. If and you know, sometimes this is difficult as a physician. You feel like you want to be or you should be the person leading this, but I would actually, from my own practice and from this consensus statement, it's advisable to have someone that may have a good rapport with the patient be that primary point of contact, someone that already has a good relationship with the patient and kind of knows what makes them tick and what makes them calm down. That would be advisable and probably the most ideal situation. Designating one person can really, really be helpful. And furthermore, when you're communicating and establishing verbal contact, it's important to remain concise, be very clear, use simple verbal verbiage, try to avoid complex verbalizations, long discussions. People that are acutely going through some sort of aggression or agitation, they're going to have difficulty with processing information. So utilizing very concise speech is important. Be very clear. Do not have like a high tone of your voice either. Try to speak quieter than them so that it forces them to be a little more quiet to listen to what you're saying. But Maybe if they're having difficulty processing or listening, repeat yourself a few times. And repetition is essential to getting your point across. And be very clear with establishing choices for the patient that they can use so they feel that they have some locus of control on the outcome of the situation, whether that be offering to sit down and talk in a room, in a private room, or even giving them some sort of choice of what medication might be most helpful for them. And you want to try to avoid restraint or seclusion as long as possible. That should be only at the very end or last resort for managing this kind of situation. Now, moving on to talking about the psychotherapeutic approaches and psychopharmacological approaches for managing emotional lability or affective instability. It can be used as a target for treatment, and that's because emotional lability is a major cause of morbidity. We kind of already talked about how it can indicate a significant impairment in functioning. You can even see patients struggling with expressing themselves, struggling with maintaining a rapport with people, struggling with functioning in various different settings. And emotional lability can even predict suicidal ideation and non-suicidal self-injury, along with other things. Although the neurobiology is still not fully understood, findings suggest that similarities exist even across disorders, and research suggests that, importantly, it's a treatable phenomenon. So why not use it as a target for treatment, especially when considering that someone may be going through an acute crisis? One meta-analysis, and actually the only meta-analysis available upon my literature review, reviewing the pharmacologic and non-pharmacological interventions, had goals of determining the effect sizes of interventions, whether the effect sizes vary by diagnosis, and the differences in effect sizes between drug classes. Both non-pharmacological interventions were included and pharmacological interventions. Some of the non-pharm interventions that they looked at were dialectical behavioral therapy, specifically for the diagnosis of borderline personality disorder, which targets affect regulation and distress tolerance, coordinated anxiety learning and management, and that also can be is known as CALM, and that's specifically for the diagnosis of PTSD. They also looked at emotional regulations group, acceptance and commitment therapy to target aggression in cases of intimate partner violence, and mindfulness-based therapies and neurofeedback. Interestingly, this review showed that the non-pharmacological interventions effect sizes were comparable to pharmacologic approaches. With pharmacologic approaches, the study found that antipsychotics and mood stabilizers had the largest effect size, and that these were larger in comparison to SSRIs. And still asserted that non-pharm interventions do matter and that the effect sizes are comparable between non-pharmacological interventions and pharmacological. So if a patient is specifically stating that it's a goal of theirs to not be on medication, there are definitely other avenues with many different disciplines that can get involved to help with management of this significantly distressing symptom. Other studies, so some of this specific meta-analysis suggested that quetiapine, lithium, and lamotrigine are more effective in comparison to other mood stabilizers and antipsychotics. But previous studies on the matter also suggest, again, lamictal, lamotrigine being effective, as well as aripiprazole and valproic acid, which can reduce affective instability as well. So in summary, some of the take-home points I'd like to just reiterate at the end. Diagnosis in psychiatric conditions is certainly challenging. I was faced with a very difficult case in my first year, but it served as a really great learning opportunity, and I was able to do a much deeper dive. So definitely looking around for validated scales with high reliability, looking around in literature to figure out what may be the best fit for a specific case, because certainly every case differs and every case should be taken on a case-to-case basis, wouldn't be a bad idea. You can also consider core features of a patient presentation. Rather than always trying to fit a diagnosis in a DSM-5 criteria or check off the boxes, take a look at what's actually impeding a person's functioning overall. Like in the case that I had, this individual was very distressed by the affective instability component of the presentation. So taking a look at that and considering that when making treatment decisions and proposing pharmacological or non-pharm interventions is important. Third, it's important to measure and assess affective instability over time, and it can be a strong clinical tool in considering a diagnosis as well as a treatment response. And it can especially be useful in determination of disease progression, especially when considering bipolar disorder, and as a target in crisis and acute hospitalization. And it's always important to remember and consider possible underlying medical conditions or neurological conditions that can cause symptoms of psychiatric illness. With that, I think we'll have a little bit of time for questions. Here are my citations. Thank you everyone for listening today. I hope that was helpful, and I hope that you guys learned something like I did.
Yeah, thank you so much, Dr. Tahirkheli. This was a really great presentation. You really had great information, and I learned a lot more than I fully expected. So I really appreciate it. It was really well-rounded. We do have one question. If anybody else has some questions, feel free to add them to the comments, or you can use the Q&A. But one of the questions we have is, can the ALSSF be administered by any level provider since it's self-report?
That's a good question. I think that it probably has more inter-rater reliability if the more experience you have with it. I didn't find any specific evidence suggesting that only psychiatric providers can administer it. I think because it's mostly self-report, definitely any provider could utilize it in any clinical setting.
Oh, a comment, not really a question. Well, I guess it's a question, but somebody said, awesome. Any chance to have him coming back to do our presentations?
I'll definitely think about it. Yeah. Thank you so much. I'm very flattered. I appreciate that.
Yes, you did very well. Thank you so much for this presentation. I just want to give everyone another reminder that the webinar was recorded, and I added in the comment section or the chat that you can access your certificate of attendance at the link, and the password for that is right underneath the presentation link. The other final thought on my end is that our next webinar is the second Thursday next month from 12 to 1. We really hope to see you there. And as another quick reminder, the Metro Council the Mental Health Conference is May 29th and 30th. Registration link is the very first comment I posted in the chat, so feel free to go in and sign up for that. But we'll stay on for just a few more minutes if anybody else has any questions. But again, I want to thank everybody for your time and for being here. So we'll just stick on for another minute or two, and any other questions come by. A lot of people keep saying thank you, great presentation. Somebody did mention they would love to hear a presentation about schizoaffective disorder, so that would also be interesting.
Yeah, thank you guys for your attention, and thank you for participating. I really appreciate it. You guys have been a great crowd, so thank you.
So it looks like someone's having some issues with the certificate. Let me see if I just... All right.